Morning. We're going to go ahead and get started here at 6:30, and I'm going to invite Dr. Bolger to come and introduce our guest.
All right. Good morning, everybody. It's really a great honor this morning for me to introduce someone I think most of you or many of you already know. But we're delighted to have Dr. Nehra here today as our grand round speaker. For those who don't know, Dr. Nehra is an associate professor in the Division of Trauma, Burns, and Critical Care at Harborview. She serves as the medical director for our trauma ICU and as the fellowship director for our surgical critical care program. She's a prolific researcher and has focused on health equity, the social determinants of health for our patients, as well as their long-term outcome and recovery. And I think one of the things you'll hear about today is her passion to not only help patients survive, but think about how they thrive in the community after discharge. And how can we do better by our patients who suffer many challenges before they are injured, and then certainly more challenges after they're injured. So she has been instrumental in founding our Harborview Violence Intervention program, which she's going to talk to you about today. She has been working tirelessly on this for several years, has built an incredible team, has secured funding for the program for both King County and the state of Washington. And really, I think it's a model program for the country, and other trauma centers are looking to think about how they can build such a program. So I personally have witnessed the tremendous value that our patients and their families receive from this program. So delighted to have Dr. Nehra share with you today that story.
Thanks for being here. Good morning, everyone. Thanks for being here. Thank you, Dr. Paul, for kind of introduction, and to Dr. Anava for the opportunity to present here today. I'm really looking forward to sharing with you all. I can make this work. Eventually, I'm going to be looking forward to. All right, I'm really looking forward to sharing with you all our efforts over the last couple of years. I'm really trying to develop a violence intervention and prevention program at Harborview. I have no disclosures. My plan for the talk is to talk a little bit first about some of the big picture numbers and really try to highlight those individuals who are most impacted by violence in our community. I'll then talk a little bit about what a violence intervention and prevention program actually is. And then I do want to spend the latter half of the talk really focused on our program at Harborview and how we've developed and built that program over time. And my hope is just that people leave here a little better informed about gun violence and how it actually truly does impact each of us. So in June of 2024, the Surgeon General actually declared firearm violence a public health crisis in this country. And I think this is a really important move, because it allowed us to really sort of increase the work in this space, because it framed the problem as a public health crisis, as opposed to just a political issue, which is what a lot of people think of it as. And I think the other thing he did in this report is he really highlighted the scope of the problem, which a lot of folks, I think, profoundly underestimate. He highlighted some figures that I think are pretty surprising to many people. Things like 6 in 10 Americans are worried that they will personally lose a loved one at some point due to gun violence. 50% of the kids that grow up in this country are worried that there will be a school shooting at their school. And 54% of Americans surveyed actually say that they have been personally touched by gun violence. So I think those numbers are concerning. And if you look at the numbers over the course of a year, every year we lose over 48,000 individuals due to gun-related deaths. Pretty consistently, over half of these are related to suicide. Sorry, it looks like my formatting is not great. Over half of these are related to suicide, and over 40% pretty consistently are related to interpersonal violence or homicide. A smaller number, although a really important number, are related to unintentional firearm discharges, which is accidental discharges typically, and then also legal interventions. In the United States, although we're home to just 4% of the world's population, we account for 44% of global suicide. And then if you look at the homicide numbers, we have the highest homicide rate amongst high-income countries. Our rate is 4.1 deaths per every 100,000 people, which you can see was plotted on the y-axis here. And our homicide rate in this country is 18-fold higher than the average rate for other high-income countries. On the x-axis, you can see plotted the rate of guns owned. In the United States, we have 120 guns for every 100 people. That's more guns than people in this country. And access to a gun has been consistently shown to increase the chances that you are injured by a gun. That might be self-harm and that might be interpersonal violence. So access to guns is certainly part of the problem, but as we'll talk about, there's much more to the problem than just access to guns. So if you look at the daily numbers, 125 people in this country are killed by guns every day. And we unfortunately still don't have a great way of tracking individuals who are injured by a gun, but at least twice as many are injured and are left to survive the consequences of their injury. I think countless others stand behind these individuals and are impacted by gun violence on a daily basis. So let's talk a little bit more about who these individuals actually are. Unfortunately, a lot of the individuals in this country who die or are injured by guns are actually children and adolescents. This is a sobering report that was published in the New England Journal of Medicine in 2022 that highlighted the fact that firearms are now the leading cause of death for children and adolescents. This is people aged 1 to 19 years of age. And I think you can see in this graph that for decades, there was a decrease in the all-cause mortality in this age group, which was really great to see. And the reason for that decrease is because we as a country truly embraced the public health approach to the #1 killer in this age group, which is motor vehicle accidents or crashes. And I think when you look at that, you see the impact of such an approach. In 2019, we started to actually see, for the first time in decades, an increase in all-cause mortality in this age group. And there was actually a 20% increase in all-cause mortality amongst children and adolescents age 1 to 19 in just a 2-year period between 2019 and 2021. And you can see on the right side of this graph, the lines crossing with motor vehicle crashes now killing less children and adolescents than firearms. And if you take a deeper dive, I'm really sorry about the formatting. If you take a deeper dive into those firearm injuries and that increase in the last couple of years, what you'll find is that that increase between 2019 and 2021 is disproportionately concentrated among Black men. And actually the increase is primarily related to homicides, with only a very small increase in the suicides. And in just that period of time, a 33% increase in crude homicide rates for individuals in that age group. And that sort of increase in firearm-related deaths amongst Black youth in this country is actually a trend that started back in 2013, and you can see that here in this graph. And it was actually significantly exacerbated during the COVID-19 pandemic. There's probably a lot of reasons for this, social unrest, economic instability, a lot of which impacted disadvantaged communities more significantly, but it's actually a divide that's been increasing over the years. And this is not just a problem of Black youth. Across the age spectrum, when you look at it, Black individuals in this country are disproportionately impacted by gun violence. And if you actually look at the numbers, non-Hispanic Black Americans are 10 times more likely to die by homicide related to guns and 18 times more likely to be injured as a result of a gun compared to non-Hispanic white Americans. And I just want to, for a second, come back to this graph again, because once again, I think we see a problem, we see a real problem, but we also see the solution to this problem, or a potential solution to this problem, right? We know how to do this. We've done this as a country in terms of taking a public health approach to a problem. We did it with tobacco use because we cared about it. We did it with motor vehicle safety because we cared about investing the resources to really do this the right way and to make an impact in this space. And I think this is a tried and true playbook, and we know how to do this, and it takes a lot of work and resources. It takes studying the problem, trying to figure out who is most impacted, right? It takes actually coming up with solutions to the problem and then really trying to implement and scale the solutions that work. And I think we just have to care enough to do this for this problem. So it's much more about sort of being black or white. It's about what's happening in communities and where individuals are living. And there is a growing body of literature that makes it clear that firearm deaths and injuries occur disproportionately in communities that are impacted by historic disinvestment, poverty, and lack of opportunity. And there's lots of different ways of looking at community level health or vulnerability or deprivation or opportunity, whatever you want to call it. And the idea behind all of these indices is kind of the same. I've looked at a couple of them that I've worked with in the past. The idea is that you're taking different sort of important measures of what's going on in a community, and you're trying to come up with some metric to grade the health or the deprivation or the vulnerability of that community. The social vulnerability index is one of the most commonly used indices and has the different components you can see here, but all the indices kind of try to get at some similar things. We used the social vulnerability index and published a paper in JAMA Open in 2013, where we actually looked at the relationship between community level social vulnerability and youth firearm deaths due to interpersonal violence. So this is, again, those 1 to 19-year-old individuals. We excluded self-harm or suicide, and we looked just at interpersonal violence. We looked at a national sample, and we said, let's look at the relationship between homicide or death rate due to interpersonal violence or homicide and community level social vulnerability. And as you can see here, there is a clear stepwise increase in the death rate per 100,000 person years for youth, such that youth that were living in the most vulnerable communities were 11-fold more likely to die of firearm-related violence as compared to youth living in the least vulnerable communities. And our study period just happened to span the time of the COVID-19 pandemic. And so we looked at sort of what was happening over time during the study period. And we certainly saw an increase in firearm-related deaths in this age group during the study period. But when we broke it down by social vulnerability, we again found that the most vulnerable communities were bearing the greatest burden of that increase in firearm violence that we were seeing. The highest SVI communities are the top line in that graph here, and you can see the slope of the curve is different than the other SVI communities. I'm not going to talk too much about firearm legislation or policy today. I'm not an expert in that. But in this study, we did look at state gun laws and tried to look at whether the relationship between community level social vulnerability and firearm death rate for youth held in states that had strict gun laws, which are the Gifford A and B states here, and states that had lax gun laws, or whether there was any differences we saw here based upon the strength of the state's gun laws. And as you can see, that relationship with a clear stepwise increase in firearm-related death rate related to interpersonal violence for youth held, regardless of whether you looked at strict or lax gun law states. And this is by no means to say that firearm legislation doesn't matter. Of course it does. And actually, the states with the more lax gun laws had a significantly higher number of deaths overall due to firearm violence. But that relationship held. So I think it's about more than firearm legislation. You really do need to be thinking about where these injuries are occurring and what's happening in these communities that are seeing these injuries. And I think the problem is that it's clear that violence is oftentimes concentrated in disadvantaged communities. But when community violence continues to be concentrated in marginalized communities, that actually perpetuates existing patterns of racial and ethnic disparity. And I think a lot of what we know about things in general, but especially this problem comes from the media, right? And the problem is that the media has a tendency to disproportionately report on events of gun violence. So if you look at it, there's actually studies that show that the media disproportionately reports on certain types of gun violence. So they tend to report more on mass shootings, which won't be surprising to anyone, I think. Also, children and women when they're injured. And then injuries or acts of violence that occur in higher income areas. And so when sort of, the general population was surveyed, 25% of individuals truly believed that mass shootings were the #1 cause of firearm-related death in this country. When in fact, if you actually look at the numbers, mass shootings account for less than 1% of gun-related deaths each year. And the problem is that, I think we all know that the way the media reports things can impact our view of reality and what we think is happening. And if that happens, And then people think that, these are the problem areas, and we start to invest resources in those problem areas. We're at risk for actually investing our resources in communities that are not necessarily the most impacted by this problem. I also think it's really important to accept and recognize the fact that people aren't just choosing violence, right? People are getting to violence because they don't have other opportunities. They don't have other options. There's a lot going on in their life that gets them to that point, and you have to understand that and accept that in order to sort of try to figure out what you're going to do about it. And every time I talk about statistics and every time I think about statistics, I always like to remember that behind each of these numbers and behind each of these statistics, there's actually real people. And we don't have a lot of opportunity to honor the lives lost. This is a really nice memorial that was set up each day that puts a picture or a plaque up for every person who dies as a result of gun violence in this country. And I think you have to remember these are real people. They're oftentimes young people, and they're dying in this country as a result of a very preventable problem. And I think behind each of these individuals stands a family and stands a community that is grieving that loss and continues to grieve that loss for extended periods of time. And I think when you think about what's happening in the community, the trauma that community experiences as a result of continued acts of violence and economic disinvestment and poverty that they're experiencing day to day, there's a cumulative trauma from all of that that adds up to much more than the sum of the hurt and the suffering of the individuals who are injured. And I think that's a really important thing to recognize about these communities. And out of that comes this concept of trauma-altered identity, which I think a lot of our patients struggle with. So when you have a prolonged exposure to violence and you combine that with community-level conditions like racism or systemic racism, that can actually fundamentally change the way a person views themselves and they view society. So people can actually find themselves trapped in the assumptions and biases of others. Like, for example, if this is what people think I am and who people think I am, and this is what society thinks of me, maybe that's actually who I am. And in that process of being caught in these biases and assumptions, people can be prevented from actually charting a healthy life course. And I think this is a real reality for a lot of the young people we take care of. Like I said, I'm not an expert in sort of the solution to this problem or firearm legislation, but I think people would agree that there's multiple important components to addressing this problem. And certainly firearm legislation and policy is an important part of this work and not something I'm going to touch too much more on today. But if you understand where these injuries are happening and what's happening in these communities, I think it's clear that deep, long-term committed investment to marginalized communities and really trying to uplift the health of those communities, the opportunities for individuals in those communities is a critical part of this work. I also think that there is a really important role that we at hospitals and especially at trauma centers can play in really trying to change the narrative for individuals who we see who are injured by gun violence and their families and their siblings and other individuals around them who are at risk. And I think that sort of work that we do at a trauma center has to be really interconnected with what's happening in the community. And these efforts only work if they're paired together. So in order to really talk about actually changing the narrative on something, right, you have to think about and understand what that narrative is. And a lot of folks have worked in this space and we've previously published in this space, just trying to first understand what does life look like after discharge for individuals who survive a firearm, right? And certainly, like many of our injured patients, there's physical challenges that people struggle with, and that might be a small wound or it might be a new spinal cord injury, right? So it can span the spectrum. But when you look at the mental health consequences after violent injury, patients who are injured by violence struggle much more with mental health consequences. So we studied this a few years ago, and 50% of patients who are injured by violence will actually screen positive for PTSD 6 to 12 months after their injury. Many of them will also struggle with anxiety and depression. And I think, I've touched on some of the underlying issues in the community. There's a lot of factors that are contributing to that violent event happening in the first place. Oftentimes, this is related to issues with social determinants of health and other things that are happening that are actually the root causes of violence. And after you're injured, those sort of factors don't disappear, right? They don't go away, and they're usually actually exacerbated such that, you're actually struggling more with social determinants of health as you're trying to recover from this injury. I think fear, hopelessness, difficulty reintegrating back into society in a positive way are real common narratives. And if you just put yourself in this person's shoes, right? They were injured by a violent event in a community that is their home, and we take care of them and we discharge them back into that same community and that same situation that they were in the first place. And I think the challenge of sort of trying to reintegrate positively and feel safe is real for our patients. Our colleagues, Dr. Rolani and the group actually also studied out of Harborview some of the long-term outcomes when it comes to like likelihood of repeat injury for survivors of firearm-related injury. This was out of Harborview, and when they looked at it, they found that patients who were injured by firearms and survived a hospital discharge were 21-fold more likely to be rehospitalized for another firearm-related injury. They were over 4-fold more likely to die of a firearm-related injury, and they were 2.74-fold more likely to be arrested for a firearm-related or violent crime. So I think no matter how you look at it, these individuals are often struggling after discharge. And I think when you're thinking about the solution to this problem, it's natural to really hope and wonder if a simple solution that's not very resource intensive and that's pretty easy to implement might actually change the narrative for individuals. And again, Dr. Rolani and the group actually studied this, and this is one of the few randomized controlled trials that exists in this space, and I'll talk about some of the reasons for that. But essentially what they did was they implemented a non-intense phone-based social work, primarily phone-based, not entirely phone-based, social work support system for patients who were injured by firearm violence. And they looked at whether that type of support actually changed the sort of long-term outcomes, and they specifically were focused on repeat injury and subsequent arrest. And this intervention, importantly, wasn't paired with peer support, individuals or credible messengers who had a lived experience with violence. It wasn't paired with sort of resources to address underlying social determinants of health. And it wasn't really paired with a deep partnership with community and community organizations working in this space. And that was the design. The design was to actually try to see if something relatively simple and easy to implement worked, and it didn't. It was a negative study. It didn't change these outcome metrics, and there's a lot you can talk about with the study and the outcome metrics. But I think it led a lot of us to sort of really believe and understand that in order to really move the needle in this space, we needed to be really focused on interventions that were going to be much more intense. And so that's kind of the idea behind a hospital-based violence intervention and prevention program. The idea is that, you know, a patient comes in after an injury, you're trying to put all kinds of support into place around that individual so that they can hopefully heal and recover from their injury, right? Which is challenging enough, but then so that you can hopefully get them on a path to change their life course and stay safe and stay alive and actually have a healthy life. I think there's several different important components to a violence intervention program. And these programs are popping up across the country. And I think because of different funding mechanisms and different hospital systems and whatnot, the sort of nuance of how the programs are set up can differ. But I think some of the core important components of programs like this is, number one, making sure that you have individuals providing peer support who are often ideally from the community and have some sort of personal experience with violence so that they can actually be credible messengers. Like me walking in to talk to someone about what's going on with their life, it doesn't work, right? But someone who understands and knows and can relate to an individual going in and talking to someone about what's going on in their life and how we can help them is a much more effective way of doing that. So that's one really important part of this. I think we've recognized that without actually having the resources to address underlying social determinants of health and issues that are going on that contributed to that violent event happening in the first place, we're not going to be very successful, and really trying to ensure that you have funding to sort of address some of those underlying issues is really important. I think, of course, walking alongside patients in their mental and physical recovery, and really when they're open to it and able to engage, ensuring that we have and are trying to allow them to have access to mental health care, which is really challenging for patients in general in our system. And then the other, I think, really important part of this, which a lot of programs struggle with, and we've struggled with how to do, is yes, it's about healing and recovering from the injury, right? But it's about more than that. I think a lot of our patients need longer term mentorship. They need help with like sort of educational attainment or applying for jobs or really actually trying to get to viable alternatives to violence and economic stability. And I think trying to figure out ways to really put that mentorship into place is really important. So around 2020, I think Dr. Bulger and I had talked about how we wanted to try to develop a violence intervention and prevention program at Harborview. We didn't really know what that was going to look like. We didn't have any money for it. It felt sort of overwhelming because we have a lot of patients who are injured by violence who make contact with Harborview. And our catchment area is so broad, which I think introduces other challenges. What we knew and what I knew at that time is that we shouldn't and we didn't want to be sort of doing this work in a silo in the hospital. It really, in order to work, in order to have that long-term mentorship component, we really needed to be doing this work in close partnership with the community. And I spent a fair bit of time trying to figure out who was in the community working in this space and what work they were doing and who they were working with to try to just understand what resources already existed in the community. And as I was sort of putzing through this, not really having any direction and not really knowing how we were going to actually develop this program, of course, the pandemic was happening. And we at Harborview felt that, I think, on a daily basis, where we saw a significant increase in the number of firearm injury patients we were seeing. We were on the really steep part of this curve here then. And I think those of us who work there felt that on a regular basis. And it's never good when the Wall Street Journal picks up on sort of what's happening in your city or in your area. And what was happening in Seattle overall and the county was a mirror of what we were seeing at Harborview. There was actually a really significant increase in firearm-related injuries and deaths in Seattle and in our King County area. This is homicide rates plotted over time, and you can see that Seattle is this light blue. There was a really steep increase in homicide rates during this time. And even sort of what was happening in Seattle was out of proportion to what was happening in the United States overall and Washington. Certainly there was a few other cities that were very deeply impacted by this, but we certainly had a problem in Seattle. And I felt like every day that went by that we didn't have a program in place and where we were seeing these rising numbers was a missed opportunity. And so around this time, you know, what we saw at Harborview and what we were feeling was certainly felt by the community. And several of the community-based organizations, several of which I had been in touch with previously, came together and they said, look, we like need to come together to work in this space and to band together as a collective to try to say, hey, we're going to come together and we're going to try to address gun violence in King County using a public health approach. This collective was called the Regional Peacekeepers Collective, and we at Harborview were asked to be the 7th member in this collective. And I think that was really powerful for several reasons. Number one, it actually truly brought us as a hospital together with the community and the community-based organizations that were working in this space. But I think coming together and saying, hey, like we're all in this together, really allowed us to advocate for and to push this work forward in a way that each of us individually would not have been able to do. With that sort of joining in the collective came the first like little bit of funding for the program, and that's sort of how the program started. We got a small amount of funding from King County to support one peer support individual, an intervention specialist at Harborview. And the idea would be that this would be someone from the community who had a lived experience with violence, who would provide peer support in the hospital, and we would that funding would pay for that individual's salary. And then with these partners in the community that we had through the collective, when that patient was ready for discharge from the hospital, they would be connected with one of the community-based organizations to continue that support after hospital discharge. It's not the perfect model. It's missing a lot of the important components of a well-developed violence intervention program, but it felt like a start, and it felt like a start that we needed to sort of jump on at the time. And of course, if you're sort of under-resourced and barely have any resources to start a program, you have to be really thoughtful about your reach and sort of, having a limited group of patients that you're going to be able to serve. Because the worst thing you can do in this space is overpromise and underdeliver, right? So we started interviewing for the position, and I met Paul Carter, the third. Paul is actually someone who's been personally impacted by gun violence. He was injured a few years ago, seriously injured, was at Harborview for several months. Eventually, he was discharged. And Paul is an incredibly resilient human. He recovered from his injuries. And he, of his own accord, before I ever met him, was volunteering at the hospital because he wanted to give back to the hospital that had saved his life. And he was volunteering just by sitting with patients and listening to them and talking to them. And Paul is a really good listener and a really good talker, and just providing peer support to patients in the hospital. And when I met Paul, it was totally clear that we really wanted to have him as our first intervention specialist. And for Paul, this was an opportunity to actually take what he felt like he was meant to do and was doing on a volunteer basis and actually make a career of that. So it was truly a win-win for both sides. When Paul started in this work, I think you always worry about one person who's so deeply impacted by violence themselves working in this space and being alone. And so we worked hard to just try to have a small community around Paul and to limit sort of what he wanted to do and to sort of protect him in that work. But we had a lot of folks at the hospital who donated their time to this effort and really tried to sort of get this program off the ground and make it work. And I think, on the one hand, you can be like, Paul just provided peer support, but I think the peer support that he provided for patients, even in that first year, was really meaningful to a lot of patients. And I think a lot of us, and many of us are guilty of this, come to patients who are injured by violence, and we think, you're somehow different than me. What's wrong with you that this would happen and that you would end up in this place? And Paul always comes to it with, what happened to you in your life that you ended up here? Like, what's going on in your life that we can help you with, that you're struggling with? And I think that's a very different approach and a very different feel for patients. And so we did that for about a year. And of course, the whole time I was itching to have more funding to build this program, to build a support structure around Paul in this work. And we were lucky because I think this problem was gaining some momentum. And around that time, the Washington State Department of Commerce actually established an Office of Firearm Safety and Violence Prevention. And there was a fair bit of funding that came with that. And the funding was for programs that would work to decrease the impact of gun violence in the state. We applied for funding in 2022 and were awarded over $1 million to really build and expand this program over a 3-year period. And with that, I think we were actually able to build the program that we wanted to. We now are currently funded mostly in terms of amount of funding from the Department of Commerce. We also get some funding still from King County and then from the city of Seattle. We spent at least the first year really thinking about how we build this program, who we need to have working in this space, and then the process of interviewing and hiring multiple individuals and hiring them on with grant funding is a challenge, as you can imagine. So it took a little over a year to get the program fully staffed. This is the current team. So I'm the medical director. Laura Johnson is a social worker. She was the head of social work in the emergency department. And she's now the program manager and clinical supervisor for the team. And she's one of those people who dedicated so much of her time to supporting Paul early on when we had no support for her. We were lucky to hire her full time in that position. And then of course, Paul is with us as an intervention specialist, and we were able to hire a second intervention specialist, Terrell Harrison, who also has a very personal experience with violence himself. And funny enough, Paul and Terrell went to high school together just randomly, so they've known each other for a really long time. And they're a really good complement to each other. Paul's kind of the nice guy, and Terrell, is a nice guy, but he comes at it a little differently. He's gonna kill me for saying that. We do have a full-time social worker. So our social work group at Harborview is very overextended, and we felt like we needed a dedicated social worker for the team to make sure that the things we were trying to do were actually happening. And then we have a resource navigator also full-time. I'll talk a little bit about her role, but if you've ever tried to actually navigate any system, medical, funding that is available to victims of violence, it is extremely challenging to navigate those kinds of applications and systems. And Balloon's an expert in that and helps patients navigate that kind of system. I've talked a little bit about sort of how important and how real the mental health consequences of injury are. And we have a half-time FTE for a trauma therapist dedicated to the program. And then we have an awesome administrative assistant. We just hired a budget fiscal analyst. There's funding from different places, and we needed help managing that. So the team, once fully functional together, came up with their mission statement. And I think it perfectly encapsulates the work that they do. They say the team is dedicated to bridging gaps between healthcare and existing community resources through committed engagement to promote health for patients and individuals impacted by gun violence. So I want to talk just a little bit about what this looks like on a day-to-day basis and how we integrate this team into the care team of patients. So, when patients come into the hospital and are injured by violence, they come through the emergency department. And depending on sort of when makes sense for the patient, depending on what's going on with them, obviously it differs if you're having an emergency operation or if you have a relatively minor injury. Paul or Terrell will screen the patients themselves, figure out who made contact with the hospital, and then will go introduce themselves to the patient at a time that makes sense for that individual patient. They'll make contact with the family when appropriate. They'll oftentimes start with like really basic things like just checking in with the patient, introducing themselves, helping with parking vouchers, helping families that are already struggling with like making sure they have a place to stay so they can actually be close to their loved ones while they're in the hospital. And then the thing about Paul and Terrell is that they keep going back. They go back over and over and they just sit with patients. We've taught them, I haven't, but the team has learned about coping strategies, breathing exercises, other things that they can help patients do. They have themselves built a whole sort of library of resources that they have to offer to patients to help them while they're in the hospital deal with sort of what's going on. And they offer those to patients and they sit with them. But most importantly, they just sit and listen to them and they figure out what's going on with them and they figure out, how we can actually help this individual recover and sort of get to a better place. And like I mentioned, there's like lots of things that the team has put together, lots of grief journals, books, headphones to listen to music, board games, whatever it is that sort of helps someone take their mind off of some of the heavier stuff going on. And sometimes it's a very particular thing that's going to help a specific patient. And one of the really nice things about the funding through Commerce is that when they gave us this funding, they kind of said, there's not going to be a lot of like rules with this, which is unusual for funding, right? We don't really know how to do this. We trust you guys to do what's right and use the money in the way that you think. And we, of course, report back to them, but we've had a lot of freedom to sort of build the program the way that we felt like made the most sense, which has been, I think, really nice. Paul and Terrell had a patient not that long ago who was a young individual who is newly quadriplegic from their injury, which is, I think, a challenge for anyone to sort of cope with. And he was really struggling. And they kept going back and they just couldn't, it was Terrell mostly, couldn't get this patient to open up to him. And eventually he just learned from the individual that he had always wanted a pair of Air Jordans. Like that's something he had always wanted. And of course he couldn't walk anymore, but Terrell bought him a pair of Air Jordans. And that was a turning point for him. He put the shoes on him and it made this individual feel like someone actually really cared about him. And it gave him a sense of his humanity back. And I think it was a turning point for him. So I think really taking the time to learn what's going on with patients and trying to just figure out ways to support them and make them really feel cared for is really important. The team does all sorts of things like listed here. One of the big things, I think folks oftentimes feel unsafe in their living situation. So we can also help with temporary relocation and housing. We do try to provide employment and education support long-term. That's mostly through our community partners, which I'll touch on. And certainly there's patients who make contact with Harborview who die and who don't survive. And we provide bereavement support and help cover funeral expenses so that we can honor that life loss and support that family in that loss. So the team takes care of patients, I think, throughout their hospital course. Through the hospital, I've sort of talked about, but when they come back to clinic, they sort of integrate into different clinic workflows, try to stay out of providers' ways, but sort of make contact with our patients and keep track of them when they come to clinic so that they can check in on sort of how they're doing and whether there's anything that was missed after discharge that we might be able to help them with. We still are deeply connected to our community-based partners. And so when that patient kind of no longer needs to be at Harborview anymore and doesn't need to be coming back to clinic visits and stuff, that's when we really transition them to one of our community-based organizations. Our partners have evolved over time, and I think will continue to evolve in a positive way. But we have some really awesome community partners who kind of have different areas of focus, and we pair individuals up with one of the community-based partners for sort of long-term support in the community, and also for that longer-term mentorship, just based upon sort of where they are in their life and what they need. Community Passageways has been one of our key partners since the very outset. It's actually a program that was developed in 2017 here in King County. And like one of the programs, for example, just to give you guys an example, the Community Passageways has is this deep dive program. And this is a program that really tries to provide intense mentorship to youth and adolescents who are at particularly high risk for violent injury or violent crime perpetration. Tom Davis is the head of Community Passageways in the middle. This would be a program, for example, that one of our patients could be linked into if it made sense for them. So there's a lot going on in the community that I think we're lucky enough to be a part of. I don't have very much data like yet. We've spent most of the last several years really trying to build this program, but we have been fully functional in terms of staff for over a year now. And so we looked at just the numbers and who we're making contact with. When we sort of put this workflow together, we had said, we don't want to have to get consults from care teams because we're already doing enough. And so the team self-screens and self-consults on patients. They screened in the first year 536 patients who made contact with Harborview for new firearm-related injuries. A small percentage of those patients were injured as a result of self-harm, and that's typical. Most of the self-harm deaths actually occur before patients get to us. After excluding those, we were left with 499 patients. Most of them luckily survived, 465. And Paul or Terrell personally made contact within the hospital with 242 of them to provide support. There's a significant portion of patients who they weren't able to make contact with, and those are typically patients who are discharged after a short hospital course over a weekend or from the emergency department. Our ED social workers know about the program, will introduce it to patients, not as effective, and then Paul and Terrell will try to reach out to patients afterwards. And so they successfully reached over the phone 81 of those patients. I think that's a much less sort of effective way of engaging patients in the program. But if you look at the numbers, they do make contact with about 70% of patients who make contact with Harborview. That's just Paul and Terrell. Now, like how much a patient engages in or needs from the program can vary, and we're still trying to look at sort of what that engagement looks like and sort of outcomes related to that. I do want to highlight some of the work that Belen Sanchez, our resource navigator, does. And like I mentioned, she helps patients navigate the system, but there are actually funds available for survivors of violence. There's especially this crime victims compensation program that has billions of dollars, which are not taxpayer dollars, that are invested to really help individuals who are survivors or victims of violence recover, and it pays for lots of different kinds of expenses. Most of our patients can't navigate that process. It's like impossible for me to navigate. Belen personally helped submit 180 applications, 104 of which to date have had some sort of benefits paid out. And if you look at the expenses paid out, $1.7 million has been paid out in medical expenses. That's come back to the hospital. Over $500,000 has been paid out to patients in wages lost expenses, and over $100,000 has been paid out to date in funeral expenses. So I think this really matters for patients and actually matters for the hospital too. I don't want to underestimate or underrepresent how much work is being done in the community, and there's so much that's still being done sort of collectively in the community to try to make King County and our local area safer. This sort of graph touches on some of those things. But I do think that, staying connected with that, making sure our team members are joining meetings with the community and are part of the conversation is really important, because out of that comes, I think, sometimes novel and important solutions to problems that we haven't really thought about at the hospital. One of those came up a couple of years ago, just as an example, where Tom Davis, who's the head of Community Passageways, called me up and he was like, "Hey, Big D," and he calls me Big D, and he's the only person who's ever allowed to call me that, for sure, but I let him do it. And he's like, "Hey, Big D, we have a problem. When patients come to the hospital as a result of an injury, and there's like a bunch of family members and community congregated outside trying to figure out what's going on with their loved one, security is not very nice to them. They don't feel respected by security. If you talk to security, they're like, well, it's really hard for us to figure out who's who, and there's 30 people, and they're just trying to keep everyone safe," right? So definitely two sides to the story. Well, there's this critical incident response team within Community Passageways. That's basically two people, Ted Evans and Mark Rivers, who are available 24/7. And what they actually do in the community is that they respond to areas where a gunshot has gone off. That's called a hotspot, or an area where a shot was fired. And they go out and they try to figure out what happened. They try to de-escalate situations and they try to de-escalate retaliatory violence, right? So what we did is we connected our security with Ted and Mark, and it took a lot of sort of pulling strings to get Ted and Mark badges so that all the security officers knew them and knew who they were. So now when there's like a group of folks congregated outside, they called Ted or Mark, and one of them is available 24/7. And Ted or Mark comes and they sort of interact with the community. They usually know people. This is a pretty tight-knit community. They figure out they figure out who really needs to be updated by the medical or the surgical team, and then they help de-escalate the situation. And it's a win for security because they can keep everyone safe, and it's a win for the community because they feel like heard and respected. And it's also a really nice way where we can take community and integrate them into the hospital and show the community that, you know, Ted and Mark are part of our team, right? And that sort of interplay is possible. We'll spend the last few minutes talking about sort of big picture next steps. Certainly securing funding, it's up this summer, is a really big thing for us, and I think something that better happen. I think making sure that the staff is well supported is really important because this work is really hard, especially for our intervention specialists, and making sure that they have the support they need to stay in this work long term. We also really try to think about their career development and getting them to conferences, and when we're hosting things or we get, you know, requests to be interviewed for this, that, or the other, and whenever appropriate, we try to put that sort of frontline team forward. Paul wants to get a master's in social work, so we're figuring out how to support him in doing that. And then Paul and Sherelle both came to us and said, we want to be involved more on the prevention side. And so we figured out a really unique partnership with the Stop the Bleed program so that when those courses are being taught at high schools, Paul and Sherelle go out, they help teach, which is empowering for them, right? But they also get to make contact with youth who are oftentimes high risk in that setting, which is different than the hospital setting. Sustainability is a huge problem, right? Most of these programs across the country are funded by research, and that is a very uncomfortable position to be in when you have so many people's salaries dependent upon funding support that you're not sure you're going to continue to get, right? There's no funding for this or their salaries that comes from the hospital or the department or anything else. It's all grant-based. And so there is sort of a push to try to make it so that Medicaid will reimburse the peer support services that we provide, which I might be biased, but I think is really critical for the healing of our patients. There's 8 states that have successfully passed a bill that allows for this, and most of our patients have Medicaid insurance. And so we've been working last 2 years, although we failed to date, with State Senator Tina Orwell and trying to pass a bill like that to make Washington the next state where we are actually able to reimburse for the services that we provide. If we get funded for the next cycle, we're going to work on trying to partner with our other level 2 and 3 trauma centers to build sort of a statewide network of support. And then the last couple of minutes, I'll just touch on the evaluation part. Evaluation is a very touchy subject in this space. It's taken us years to get our team comfortable with any sort of evaluation in this space. And they now understand that it's important to evaluate and to evaluate well, right? But the concern is always that they don't want to burn the trust that they have with patients by sort of making this a study. And the community is concerned that, you know, we keep evaluating in this space and nothing ever changes and people are just sort of benefiting, but they're not benefiting. And so I think you have to sort of be really thoughtful about this. For anyone who's interested, there was this really nice overview in Nature a couple of years ago that really talks about how you evaluate in the space and how you do that collaboratively with community, and sort of has some really important points for folks working in this space. But I think one of the problems and one of the reasons there's not a lot of high quality literature in this space is because firearm violence remains one of the least funded areas of research per life lost. So $63 per life lost compared to something like HIV, where you have over $180,000 invested per life lost in research funding and a lot of things in between, right? The only thing less well funded is falls. So a lot of opportunity for improved funding. And I think that's starting to happen so that we can design really thoughtful patient-centered evaluations. The only thing we've done so far is, that's not about my formatting. The only thing we've done so far is had patients complete a survey at program completion. This is the demographics of the patients who did it, but I'll highlight just some of the free form answers. When we asked them what was the most important thing the program did for you, pretty uniformly, it was the support that Paul and Sherelle provided. Things like Paul's chat stop with my spirits, just caring, made me feel like I wasn't alone, helped me to feel hopeful again, motivated me to do well, and people genuinely cared. Certainly, are there things that we could have done better? We asked them. Nobody, I think, felt super comfortable telling us. But one of the things for the residents in the room, don't take so much blood every day. So think about the labs you're getting. Patients notice, I swear. Daily labs until discontinued is not cool. And then what are your longer term goals? And I think if you look at this, and Paul and Terrell really tried to sit down with patients and really at least get them thinking about long-term goals. Most people just want to have a normal life, what they consider a normal life. They want to work, they want to support their families, they want to just work and do good, as one person says. And I think those are endpoints that we should be able to accomplish. The thing about the Washington State Department of Commerce funding is that we're funded. Several of our community-based organizations are also funded in parallel, which has been really awesome. And then the Department of Epidemiology and the Firearm Injury Research Prevention Program, I will say it not quite right, is also supported. And the goal of that group is to try to actually collectively figure out how we evaluate in this space. And I think you have to be really careful about this. You cannot evaluate a two-year program like this based upon trying to move the needle with regards to the number of injuries that are happening in our county, for example. That's not a fair metric. You're going to fail, right? You need much longer term investment in order to move the needle on things like that. But there are immediate term outcomes that are important to us, important to our patients, more importantly, and important to our community. And so this work group actually did several sort of in-person work groups, talk through some of the important metrics that we need to be thinking about, and put out this collaborative paper, which includes a lot of community-based partners led by Dr. Schleimer, who does a really nice job in this space. And really, I think delineate some of the important intermediate and sort of longer term outcomes that we need to be focused on. And we're really in that intermediate outcome phase. Lastly, I'll end there, but I do want to thank the residents for really allowing the violence intervention and prevention team to be fully incorporated into the care team, and making the time to talk with them and check in with them about patients. Our group, the trauma burn group at Harborview, for doing the same, but also allowing the team to infiltrate clinic and sort of making them feel home and all at home in all of these environments. Dr. Bolger for allowing me to and trusting me to lead this program, and really being there as a source of support for all kinds of things along the way. I think it's, I really want to highlight also Mark Taylor, who's one of the senior administrators. There are a lot of things that I've asked the hospital to do over the last few years that at the outside weren't really normal or popular, right? And Paul, as an administrator, has really made it his mission to try to help navigate the system in a way that if something made sense, we would try to make it work, even though it maybe wasn't the way we typically do things. And he has been an incredible source of support for the program along the way. And then our CEO, Summer Cleven-O'Reilly, also for her support. I'll stop there and leave a few minutes for questions if anyone has any, but I really appreciate you guys being here and for joining.
So much, Dr. Nehra, for that amazing presentation and the phenomenal program you've built. We have to be out of the room at 7:30, and we have about 6 minutes for maybe one or two questions if anyone has questions, and then we'll have to stop properly at 7:30.
Thanks, Deepika. That was great to also interweave your own personal story into this. I have two-part question about sort of niche communities. You alluded to our big catchment area. What opportunities have you explored to talk to patients or intervene with patients who come from Idaho, Alaska? The second question is, I don't know if the people in the room realize how unique the situation is where you guys take care of all the kids. And so again, what kind of opportunities do you have, and what maybe blind spots as an adult center that provides awesome care, but may not have the pediatric resources that don't bring trauma to us, but we might have? Thanks.
Yeah, thank you for both of those. I think for patients who come in outside of the state, it's really hard because of the way the funding comes in. We do, obviously, we can still provide peer support to anyone who makes contact with Harborview who's injured by gun violence. There's no restrictions on that. What we can do after discharge is a bit more limited. But we have worked really hard over the last few years to make sure that we're not just working in King County, where 70% of our patients are coming from, but there's 30% who are coming from elsewhere, mostly from other parts of the state. And so we have community partners now in Yakima and sort of other high-risk areas where we are seeing patients from. I do think the reality is that a lot of level 2s and 3s take care of firearm injury patients, right? And we've been in touch with several of them, and we really hope to sort of build on that over the next few years, so that what we've learned we're sharing. Everyone doesn't have to reinvent the wheel, and so we can really sort of work together on building sort of community partners and networks of support that those trauma centers can also refer patients to. Our team has also set up a hotline so that trauma centers that are taking care of patients and don't know how best to support a patient can actually reach out directly to our program manager and help get them direction on how to do that. So she is available for that. You're right, we do take care of both pediatric and adult patients at Harborview. A significant proportion of patients who are injured by gun violence are pediatric. I think we're really lucky to have really good pediatric providers in the hospital who we've partnered with closely. Obviously, the intensivists are oftentimes shared between children's and here. And although we provide a lot of acute care for those patients, sometimes their rehab and their subsequent long-term needs are happening over at Children's. We actually have partners in the rehab group at Children's who we've been working with, and we're trying to figure out a way to see if Paul or Terrell, or maybe our next intervention specialist who might be more peds focused, would be able to sort of provide longer term support over there. So I think definitely an area for us to work on and grow in.
So Big D, I have yeah, you shouldn't have shared that. A comment rather than a question, and because the first half of your talk, I was depressed, and the second half really optimistic and enthusiastic and hopeful, and I want to, and so my political statement here is just mine. It doesn't represent the views of the department or the university, but I guess when I look at the first half of your talk, I think we are going backwards and we're going into a dark age that I am very troubled about. Aspects of social determinants of health, any control of gun violence is likely to be worse in the coming 4 years than it has been, making all of that aspect of prevention more difficult. And my hopeful part and my optimistic part is that we go through pendulums of politics, and that the work that you're doing, this work at the local level that makes a big difference for people at the local level, can still happen in spite of the environment changing, and can set the foundation for a positive future when we are in a better place for making other system changes that can take the work that you and your colleagues are doing and can cascade that more broadly. So I'm saying that because it's a realization for myself, and I'm saying it for maybe a realization of others in the room, of looking to do something similar to what you're doing, the things that you can do that impact real people in real time at the local level, that hopefully can be relatively insulated from other political winds, and can still make a big difference in people's lives, like you and your team are doing. So I so much admire this work and think it sets the groundwork for, hopefully what can be a positive opportunity for similar programs regionally, nationally. And thank you for doing it. Big D.
Gonna have to let that one go. I know, I appreciate that. I think none of us really knows what's going to change with the changing political climate, but I think that there's enough momentum behind this kind of work, and I think enough people recognize and are recognizing that this does truly impact a lot of Americans. And I'm hoping that we can have continued bipartisan support despite some of the change in the political climate for this work. I do think there's enough momentum and there's enough groups engaged at a national level that like we're not going to just stop doing this. We're going to figure out a way to move forward, even if funding falls through. So I think that's how most people. All right, thanks everyone.